Hello, I'm glad to be among you today. We are in the second series of ASCO-GOIS International Webinar and Certificate Game-Changing Global Oncology. Today is the second webinar, uh, uh, but I'll present first a resume from the first webinar because it's the same topic, and then the details in the second part today. I am Ahmed Elzawawy, as you know, and chair of Win-Win Initiative, chair board of directors of Global Oncology Implementing Science, GOIS. It's part of GoU, and here is the link. Founder, president of ICDoc Experts in Cancer Without Borders. Here is the link, icodoc.org. Past president of Aortic African Organization for Research and Training in Cancer. Professor of Clinical Oncology, South Carolina University, Egypt. Yes. Disclosure of conflicts. I have to repeat it, but it is needed usually. None. Okay, disclosure of conflict. Not. I don't take fees for my lecture out of my university or financial support from any. What it means that is in our forum of voice, we are free completely to express based on science. I am aligned only to what could be beneficial to millions of patients with cancer, regardless who they are or where they are. So it is an opportunity to all to express freely with scientific approaches or references or reference. Welcome all. The GOIS forum belongs to all the willing. As you know, we adopt always free flow of ideas, flexibility of thoughts, short innovation plus exploration of older and classic ways. The big brainstorming hypothesis here is we claim that the field of scientific studies of radiotherapy and allied sciences is still in need of many research, study, and game changing. What do you think? This is an invitation for discussion for all. This brainstorming is meant as starting of stimulating point. Its value depends on your discussion, feedback, modification, constructive criticism, etc. We welcome all your feedback before, during, and after the webinars. Please take some of these points to discuss in your institute organization, even to publish your outcome. We don't claim any ownership, and we repeat this always along the series. Why more research is needed in radiotherapy and related science? Today, radiotherapy or without surgery is responsible for most of the cure in cancer. All cancer drug therapy is responsible for only 11 to 12% of cure in cancer. Maybe in the last years, it increased slightly, 1 or 2% more or something. Correct me if I'm wrong, but with reference and evidence. So despite of all these loud voices and all that, but this is the fact. The remaining is attributed to surgery and radiotherapy. 50 or 60% of cancer patients will need radiotherapy along the course of their disease. There is a growing more indication for radiotherapy in the upcoming year. The prospect is there. It is wide. In combination with new technology like targeted drug delivery, nanotechnology, and immunotherapy. As you know, despite all the efforts, organizations, societies, conferences, summits, declaration, plans, and thousands of publications, there is tragic shortage of clinical oncology, including radiotherapy service in most of the world, particularly in Africa. Although there has been a slight increase in facilities, yes, but this growth has not matched the rapidly increasing demand, despite of the loud things. Yeah? So it is needless to waste time to dispute about the gap between the needs and the available radiation therapy. That the gap between the needs and the available radiation therapy service is widened in the last 2 years, two decades, despite of all these talks. If the stakeholder continue with the same previous way, then the situation will only worsen. Will only worsen. We raise the red flag. Radiation therapy is the core of modality of treatment. However, concerns have been expressed regarding its underutilization and lack of prioritization as a research domain, compared with other treatment modalities, despite its rapid technical evolution. We know the cause, as you know, this is funds and drugs and pharmaceutical company, etc. But we should think about clinical oncology as and cancer care as combined branches related to each other and interfering with each other. This is the same patient. A total of 62,550 radiation therapy research article from 127 countries published in 2,531 international journal were analyzed. The United States was responsible for about 32% of these outputs, followed by Japan 8% and Germany 7%. But what is what we stress on? Trial-related radiotherapy applications in all journals represented only 5.1% of the total output. You imagine this, 5%. So there is a burning need for a lot of focused scientific approaches on how to increase affordability of better value cancer care via science, with consideration of the interest of all the stakeholders, their interest and their incentive and everything in the real world. An example of in our series of ASCO-GOIS international webinars focus on systemic cancer therapy. And here is the link. You will find the webinars and the full records, all free, accessible to all. Our second series is focused on radiotherapy, molecular radiotherapy combined with immunotherapy. Greater support for radiation therapy research, including international collaboration in low and middle income countries. This could provide requisite knowledge to guide future radiation therapy research program, and a win for all. All will win. Then we continue in the second webinar. Here is the second webinar. Today is the second webinar, November 26 to 2025. Why a lot of further research in radiotherapy is needed. What we present is a starting point for collective brainstorming. Its purpose is to present its purpose is not to present final answer, but to raise important questions about directions for radiotherapy research and to spark collaboration. Some example of brainstorming point is that may stimulate more radiotherapy study. That this is what we present. This is not exclusive list. This is not exclusive list of stimulating, but it is stimulating suggestion for further studies. One, radiogenomic, genetic variation, and radiotherapy response, like some types of single nucleotide polymorphism. Then single nucleotide polymorphism play this one. The first one is play a key role in understanding biological treatment response to radiotherapy. This genetic variation can influence both treatment efficacy and toxicity. An example, DNA damage repair genes. Here, for example, this variant in genes such variant of genes can alter DNA repair different efficiency, leading to increased resistivity and toxicity. These details in the slides and text present on demand. Just send to me. I send to you all. Inflammatory pathway. Engine involved in inflammatory pathway with some types of single polymorphism. It can influence the development of radiation-induced toxicity like oral mucositis. Apoptosis of and cell cycle control. Yes, also genes. Example of specific single nucleotide polymorphism associated with radiotherapy toxicity. This is the first example associated with severe oral mucositis and poor treatment response in oropharyngeal carcinoma patient. Second example is linked to increased risk of grade 3 oral mucositis in head and neck cancer patient undergoing radiotherapy. Third, associated with late urinary toxicity in prostate cancer patient treated with radiation therapy. So when we study prostatic adenocarcinoma response to and toxicity to radiotherapy or something, we should go deeper for these studies and when we study toxicity. The fourth one, potentially linked to radiation pneumonitis in lung cancer patients. More clinical implication. One, personalized medicine undergoing single nucleotide polymorphism can help tailor radiotherapy treatment to individual patients, minimizing toxicity and optimizing treatment efficacy. Biomarker development, single nucleotide polymorphism can serve as biomarkers to predict radiotherapy response and toxicity, enabling a more informed treatment decisions. Future research direction. Further studies are needed to fully and elucidate the relationship between single nucleotide polymorphism and the radiotherapy response and to develop single nucleotide polymorphism based predictive models for clinical use. There are many wide tracks of studies. There are already many studies, but is still a lot. Breast radiotherapy and pain. This is very interesting. A study on 2020 reported that 37% of patients experience moderate to severe breast pain following radiotherapy. Conventional fractionation was associated with more toxicity, pain here, than hypofractionation, supporting the recommendation to offer hypofractionation when appropriate. You imagine this? And explanation what there is a racial and socioeconomic difference? Yes, in such genes. The same study found that severe breast pain was more common among Black patients. This raises critical questions. We raise the question in race itself. Is race itself a biological predictor of breast pain, or do socioeconomic factors or scale access explain these disparities? But breast pain are more common after radiotherapy is more common in Black race. Why? It is just explained by genetics, or it is the socioeconomic factors. Addressing racial bias in healthcare and ensuring equitable care delivery are essential. We have to assess the cause of this finding, hence to improve the care of our multiracial breast cancer population. Interestingly, patients treated with teaching in teaching hospital, which is another surprising, teaching hospital with hypofractionation reported lower toxicity, a finding not observed with conventional regime. Is there different in effect of the above cited elements among races population response in different tumor and adjacent healthy tissue? For example, delay in DNA repair leads to more sensitivity to radiotherapy among Black-skinned patients with prostatic adenocarcinoma. What it means that it's more sensitive to radiotherapy. What it means that we should adjust radiotherapy, and maybe we'll get more favorable response. Not as we always repeat this bad prognosis among Black races. Maybe it's because advanced, maybe because of something, but not because of radiotherapy. Here is more sensitive to radiotherapy, prostatic carcinoma, but probably not in adjacent organ. We should take care here. This is probably not in adjacent organ or tumors like rectum or bladder, but in the prostatic carcinoma itself. Recommendation: clinical trial should go beyond dosimetry and toxicity outcome to explore deeper biological population specific factors. So what we always recommend, it may be advisable in different types, what's called hypo-Africa between different populations. Then we should, if possible, go beyond the just the symmetric, beyond the symmetric technique, comparison and outcome on toxicity, and to go versa to explore deeper biological population specific factors. Not just with hypo trials and something. There is a need for this, if possible. They need funds, they need more studies, so the prospect, the prospect is wide, is in front of you, is very encouraging. There is a need for many studies that include biology, variation in response and toxicity with different ways of delivering radiotherapy, fractionation schedule of equal doses per fraction, or not equal, and the time of session, chronology, and time of effect on time of administration of concomitant medicine. We'll discuss this now after minutes. These points are for free thinking and brainstorming that could be stimulating or not for more development by researchers and scientists. There are many points. Let us see more examples. The number of fractions per week and dose per fraction, hypofractionation. Should we get common definitions and types? Accelerated fractionation, hyperfractionation, timing of scission, dose rate, genetic or racial difference, as we said. There are many points. Some background about fractionation from the past. This is just background. I see that some, particularly the new generation, may think wrongly that fractionation in radiotherapy and the conventional fractionation of 2 gray fraction, 5 scission per week was proposed initially on radiobiological basis. No, it is the contrary. And radiobiology explained it after, and I studied it after. Or it was proposed in the beginning of the era of radiotherapy on evidence base. But in fact, in the beginning of 20th century, the output of X-ray machine was a low dose rate, very low. Then something to use it in cancer therapy. It was not even, it was just empirical. To give a good amount of radiation, then several sessions over some days were practiced. So because those low dose rate. There is a thesis even, I read it in 1906, but a thesis was done in Paris, 1906, and he said that he have to make fractionation because the dose output. There is no radiobiological basis yet. And from there arise the concept of fractionation, and then come to radiobiology to explain to us many things. And still there are many things to be explained. To give a good amount of radiation, then several sessions over some days were practiced. It was empirical before the notion of absorbed dose and the start absorbed dose and the start of understanding radiobiology that came after. The cause that frequency of number of sessions was proposed to be five per week is that Saturday and Sunday were off. This is why it's 5 days. This was it was empirical in the beginning. Then again, radiobiology come after, then some important notion come after nominal standard dose, time dose factor, alpha beta, and early and late effect of other factor, other element arise. Defining hypofractionation. This is very important. Is this a definitive consensus about the definition of moderate hypofractionation? Is that above 2 gray or 2.2 or 2.1? Or what is the upper limit, in the other word, the lower limit of ultra hypofractionation? Its upper limit is of moderate hypofractionation, is the lower limit of ultra hypofractionation. Do we consider all the following 2.1, 2.5, 3, 3.5, 3.6, etc., 4 gray or slightly more per fraction as moderate hypofractionation? It's nonsense. I don't know. I mean, correct me if I'm wrong. Our suggestion, what I suggest is to propose making subcategories rising from the lower limit of dose per fraction till the high limit of moderate hypofractionation. I think it worthwhile discussion and to conduct study and universal recommendation. What do you think? You will discuss and you will suggest, and we are many experts more knowledgeable than me who can he can study this. But we should have consensus together about this. Some history in the stimulating the text material, but I say it briefly. Personally, we applied in Teno Hospital, Sorbonne University. Now it's affiliated Sorbonne, Paris, France. When I was a resident in 1971 and after, I am old man. Was the protocol approved by the late Professor Analogier, Professor Michel Chilangier, and team. Also, it was protocol advised and used by Professor Salazar in Institut Gustave Roussy. It was 45 in 18 fraction, 4 half a week for post-mastectomy radiotherapy. So this concept of hypofractionation, as we think that's new, is not new at all. And the same plus boost for post-conservative surgery. I applied this protocol in Port Said, Egypt, in most cases from 1994 till 2015. Do you consider 2.5 gray in this protocol as intermediate or moderate hypofractionation? So we use it since a long time. Bearing in mind it was used since long time by some oncologists in Manchester and all. It was even more hypofractionation. Also, the moderate hypofraction was similar with a similar number of fraction was used in curative radiotherapy since decades in Manchester and in UK. So it is not a new surprising invention as some present it now. No, but we study it to understand it more and to adjust it. But surely it needs more deeper study that consider different different factors and new elements. This is what was needed really. Here is the references. Non-uniform dose delivery should be delivered. The delivered dose be equal L among in all sessions or part of the course. For example, in the 70s, a protocol of 4 sessions hypofractionated, 4 sessions only, but not equal doses session along 2-3 weeks was practiced by Professor François Bailly, Hôpital Necker, Paris, and Professor Jacquia, France also, for post-mastectomy and for post-conservative breast cancer surgery. Also, there are some idea by some researchers who suggested some mathematical models to deliver different doses with different days of separation between every session for glioblastoma. Mathematical model and not equal session and not equal separation days. It was published, but since many years. Note the later example should not be taken or cited as reference or evidences, but it could be start of brainstorming panel that may result in some suggestion, adjusted suggestion, not just memories, for studies or not, depending on the outcome of discussion and virtual and written feedback, both. If there is a valid rational or radiological evidence to deliver part of the course as convention and other part as hypofractionation or different type of fractionation along the course, should the radiotherapy course combine different fractionation strategy, for example, starting with hypofractionation, then continuing convention? This history also, but there's no evidence. This was done. History of thinking with no trials done. In 1980, in Centre Guinéen, I was there after Tino, France. I find that the tenure there, we use this protocol. Personally, I was among the young staff there. The usual protocol for advanced and head and neck cancer was to start with 3 sessions of 5 grays. We call it 3x5 in 3 successive days, then to continue as conventional 2 grays, 5 sessions per week. 2 gray per fraction, 5 sessions per week. This protocol that was presented and discussed with the pioneer Professor Gilbert Fletcher, MD Anderson, several times. We discussed it with him in Paris, but it didn't present any objection, and see, we shall see. But we doesn't mean that we consider in any way these memories as a references or evidence, but for brainstorming discussion and to develop evidence, if any, if present. Fractionation per week for energy therapy. How many fraction per week? Background history and brainstorming for potential perspective. 2 or 3 per week, or 4 or 5 or 6 or 7 fraction per week. We said that 5 fraction per week was proposed in early decades, and because the working days was 5 days per week, all over France and UK. What about 6 fraction per week? It may give better local control in head and neck cancer versus conventional fractionation. You imagine this. And this is the reference. It is a study of Overgaard, and it gives better local control. And here is the references. What about changing system of working in radiotherapy units and hours of working? Be 7 days per week. How this could increase the number of treated patients and access to radiotherapy and effects on total cost of running of services. Here is the reference, chapter 17, challenge of radiotherapy accessibility in post-COVID area by the Professor Data in our book Approaching Global Oncology, and here is the reference. Chronoradiobiology, timing of radiotherapy. Does the time of the day affect efficacy and toxicity? Timing of radiotherapy session along the course. Circadian rhythm and biological effect of radiotherapy. For example, what could be called chronoradiobiology. Chronoradiobiology. Does chrono-modulated radiotherapy affect the efficacy and toxicity on patient? I don't know, but there are some studies. There is difference between different biological and different circadian rhythms, particularly in some profession who have night shift or other factor in timing. There are some studies about that, but should be it needs deeper studies. This is the reference, for example, receiving radiotherapy in the morning may improve survival in patients with nasopharyngeal carcinoma, as published in the morning. Concomitant drug and chronotherapy, timing of chemotherapy also matters. A morning administration of temozolomide, Temodal, in glioblastoma was linked to better outcomes. So the concomitant drugs also and radiotherapy. More information, timing of some concomitant drugs. The article about circadian effect on administration Temodal in glioblastoma. Data from small retrospective studies suggested that Temodal dosing in morning may be associated with higher efficacy and better outcome. Chronotherapy could be a form of personalized medicine aimed to arrange the time administration, drug administration, and maybe radiotherapy according to the circadian rhythm of cancer cells and the patients. Here I add a comment to an article in Medscape about circadian disruption, the hidden cancer risk. My comment was, here is the reference, my comment was to Medscape that in fact there are many studies and research on the link between the circadian rhythm and cancer risk and the chronotherapy and the responses to drugs and immunotherapy of cancer. In addition, we raised in the second ASCO-GOIS international webinar today is the question about timing of radiotherapy session and the need for more studies in chronoradiotherapy. Does the time of day affect efficacy and toxicity of radiotherapy? We stated some difference for early study that goes with that hypothesis. Here is the reference. More timing of concomitant chemotherapy may also matter in the case of administration of other concomitant drugs. Dose rate, flash radiotherapy. More details will be in the fourth webinar. We have very exciting series in the fourth webinar. We are in the second. This ultra high dose rate flash therapy delivering 46 gray second or more show promise in sparing normal tissue and with excellent response on tumor with new radiological findings that need more studies. Both electrons and proton flash are investigated, but it remains experimental. It needs more radiobiology technology development, industrial and clinical studies. Our question is flash treatment is transient hype or true game changer? Radiotherapy fractionation immunotherapy, how do those perfraction and fractionation schedule influence the abscopal effect and immune response? I don't know. Example of innovation and research cited in this series and that time of cost implementation in modern technology of radiotherapy without compromise the outcome. Hence, you treat a greater number of patients with the same machines that you have. In the third webinar, next webinar, we present Professor Eric Ford will present low-cost radiotherapy machine and novel ring-based compensator intensity modulator radiation therapy, save time and cost, lowering the cost of image guidance and radiation therapy using low dose megavoltage imaging cone beam CT for accurate radiation therapy delivery by Professor Rosbovico. Save again time and cost and can treat more patients. Brainstorming on AI in clinical oncology and prospects. In the third webinar also. It's very, very exciting. We invite you all, please. In the fourth webinar, smart radiotherapy, biomaterial for combining radiotherapy and immunotherapy. Professor Will Nigma, and we cited other, and Ital, and we cited other innovation in the series and in our programs. Note, just a question, is the term 2D radiotherapy, two-dimensional radiotherapy, is right? In other words, is there is really 2D radiotherapy, as sometimes wrongly cited? I say it is impossible and not imaginable to produce 2D radiotherapy. Well, I propose to call it, as many call you call it, 2D imaging-based radiotherapy planning, as this what happens in fact. So what's frequently cited by resident 2D radiotherapy is not imaginable even. Some more brainstorming question for research in general and for radiotherapy. In real life research study, consume resources, patient time, physician time, patient's time, physician time, hospital resources, and significant financial cost. Therefore, this should be prioritized and guided by global needs and feasibility. A realistic and win-win approach to radiotherapy expansion, practice, and research should be designed with global applicability in mind. Final thought is our claim that field of research and study is still version field and study in radiotherapy is still version. Is this true? What do you think? The field of radiobiology, radiotherapy biology, physics, and clinical application remain widely open for studies and innovation. Some current standard of radiotherapy practice involve it empirically, like 5 days session per week, as we said, and must be re-examined. This document is starting point for more brainstorming. Its purpose is not to present final answers, but to raise important questions for discussion about the direction of radiotherapy research and to spark collaboration. This brainstorming will be of no big value except after your discussion, modification, feedback, and criticism and contribution. We invite colleagues and organizations worldwide to participate and to lead a big brainstorming initiative in radiotherapy research and implementing science. It includes and abstracts different involved sciences, allied sciences, radiobiology, cancer biology, physics, technology, radio, and pharmaco genomics and combined therapy with external, for example, external radiotherapy with without one of more immunological approaches and treatment, medical cancer or concomitant also with medical cancer therapy, targeted therapy using nanotechnology, smart radiotherapy material, all along technological engineering and industrial innovation. So it could attract and involve researchers and funds from different disciplines, not just 3 fraction, 5 fraction, or something. No, it is more wider than this. The radiotherapy is radiotherapy research in radiotherapy. I think is with this concept is still virgin. with all with you all the contribution and leadership of many experts, institutes, society, organizations, and industry, then radiotherapy with the allied science will start a wide prospect. Feel free to take some of this point to discuss with your in your institute, organization, even to publish your outcome. We don't claim any ownership. Again, we don't claim any ownership or praise. Any suggestion or model, even what we suggest, will belong to their doers. It is a big issue. I don't claim any leadership, as I am an old clinical oncologist. I have 73 years old, and I'll be 74 in the new year. So please allow me to be one of the initiators and stimulators. We need many leaders. It is a very big issue in institutes, societies. We welcome all feedback before, during, and after the ASCO seminar. It is a call to move of the excellent player in the world to a better game, one that ensures increasing affordability of better value cancer care, including radiotherapy, with dignity to millions of patients, and to that research fulfill its global potential. Thank you all. On behalf of all the leaders and faculty and experts on GOIS. This is our message. It is our message of love for all humans via science, not via talks. This is the message of GOIS. Well, we are waiting all your feedbacks now and in the future. Send emails via the web, videos, and if when you allow to us to spread to colleagues, then tell me with your email and affiliation. If you want to lead some of these points discussed in this university, please do, and please go on forward, go forward in fruitful cooperation together. Thank you all, and bye-bye.